Hi everyone. Today we shall discuss the ANTHARTIC study published in the NEJM just a couple of weeks ago, titled Prevention of Early Ventilator-Associated Pneumonia After Cardiac Arrest. Let's briefly look at what we already know about this topic. As you all know, induced hypothermia is standard of care today after cardiac arrest. However, targeted temperature management is not without its problems. You can get nosocomial infections, particularly early ventilator-associated pneumonia. Several studies have addressed the question of whether prophylactic antibiotics may be helpful in reducing the incidence of VAP in comatose patients. In fact, there are three major studies. Two of them were small randomized controlled studies, and the third was an observational study, and they all seem to suggest that the use of prophylactic antibiotics in comatose patients with traumatic brain injury or strokes may result in a reduced incidence of ventilator-associated pneumonia. However, the use of prophylactic antibiotics in patients after cardiac arrest who are subjected to targeted temperature management has not really been studied in any elaborate fashion. So the question the investigators asked was, in patients who are resuscitated after out-of-hospital cardiac arrest with a shockable rhythm, does a 2-day prophylactic antibiotic course compared to placebo result in a reduced incidence of early ventilator-associated pneumonia? So that was a clinical question that was asked by these researchers. The study population were adult patients more than 18 years of age who had suffered out-of-hospital cardiac arrest with a shockable rhythm and who underwent therapeutic temperature management across 16 ICUs in France. The study design was double-blind, placebo-controlled, randomized controlled trial. What did they do? In the intervention arm, they used amoxicillin clavulanate in a dose of 1.2 grams intravenously 8-hourly for only 2 days, while in the control arm, they used normal saline as placebo. Management common to both groups included rapid induction of hypothermia, usually with cold saline infusion. The temperature was managed between 32 to 34 degrees centigrade for about 24 to 36 hours. The technique of induction of hypothermia and maintenance of hypothermia was left to the choice of the clinicians involved. Sedation and neuromuscular blockade were administered as appropriate to both groups of patients. And in case of any evidence of nosocomial infections, appropriate antibiotics apart from the prophylaxis was administered according to local guidelines. What was the primary outcome that they looked at? They looked at early onset ventilator-associated pneumonia, defined as pneumonia within the first 7 days of hospitalization. And how did they arrive at this diagnosis? They used the Clinical Pulmonary Infection Score and the SOFA scores. They went by the chest radiograph as well as the arterial blood gas analysis. In addition, the final arbitrators of the diagnosis of VAP were 3 blinded intensivists who adjudicated on the presence of VAP using clinical, radiological, and microbiological criteria. So the final word was left to these 3 intensivists. How did they calculate the sample size? Based on pre-existing literature, they assumed an incidence of VAP of 68%, and assuming a reduction with prophylactic antibiotics by 25%, they arrived at a sample size of 163 patients for 90% power with a type 1 error of 5%. But when death was considered as a competing event, the sample size was increased by 15% to the final number of 192 patients. So how did they assess their patients for eligibility in the study? 1,116 patients were initially assessed. A large number of patients were excluded, 918 patients. The majority of them were excluded because they had either a non-shockable rhythm, the cardiac arrest was in hospital, there was a lapse of more than 6 hours between return of spontaneous circulation and assessment for eligibility. If there was any evidence of pneumonia at presentation, such patients were not included, and patients who were considered to be moribund, in the opinion of the investigators, were also not included in the study. So after exclusion, they had 198 patients. 99 patients were assigned to receive prophylactic antibiotics, and the same number were assigned to receive placebo. After withdrawal of 5 patients, 2 from the antibiotic arm and 3 from the placebo arm, in the final analysis, there were 97 patients who received antibiotics as prophylaxis, and 96 patients received placebo. What did they find? The primary outcome, as I mentioned, was early ventilator-associated pneumonia, defined as VAP within the first 7 days. In the antibiotic group, the incidence was 19% compared to 34% in the control group. The hazard ratio was 0.53. The confidence interval did not cross 1. Hence, this result was significantly in favor of the antibiotic group. The p-value also corroborated with that result. It was 0.03. Late VAP after 7 days were very few and not really sufficient to make any kind of meaningful analysis. What were the secondary outcomes that they looked at? They looked at the 28-day mortality, which was 41% in the antibiotic group, 37% in the placebo group, which was not statistically significant. They looked at intestinal acquisition of multi-drug resistant bacteria by day 7, and they could not find emergence of any MDR bacteria in that period of time. The ICU length of stay was not different among survivors as well as non-survivors in both groups. Ventilator-free days until day 28 was a median of 21 days versus 19 days in the antibiotic versus the placebo arms, not statistically significant. But interestingly, they found that the percentage of days free of antibiotics during the ICU stay was more with prophylactic antibiotic treatment compared to placebo. Of course, when you calculate the number of days on antibiotics, you wouldn't include the days that they were administered prophylactic antibiotics. So, in a sense, it meant that the use of prophylactic antibiotics resulted in less use of additional antibiotics for possible nosocomial infections. So, at the end of all that, what were the strengths of this study? Clearly, this is the largest randomized controlled study that addresses this question as to whether prophylactic antibiotic therapy can reduce the incidence of VAP in patients who are resuscitated from cardiac arrest after a shockable rhythm. The study was multi-centric across 16 centers in France, just a single country. The protocol was strictly adhered to. The follow-up was complete. And the diagnosis of VAP was made by an independent committee of 3 intensivists. The resuscitation effort at baseline were very efficient, as is evident from the fact that the median no-flow time was only 2 minutes, which is pretty good by any standards. They also performed a health economic analysis looking at the cost of care and they found that the cost of care was significantly lower with the use of prophylactic antibiotics. Now let us look at the possible weaknesses of this study as well. They did not include patients with overt aspiration. You may argue that this is a subgroup of patients who might benefit with the use of prophylactic antibiotics. You might also argue that the hypothesis may be questionable because amoxicillin clavulanic acid has a short half-life. And if you give it just for 2 days, how do you expect an effect to last for 7 days or more? The third possible weakness is VAP was taken as the primary outcome, which is not a clinical centric outcome, you may say, and perhaps mortality may have been a better primary outcome, or perhaps even neurological outcomes may have been a more robust primary outcome. The diagnosis of VAP is a little bit open to question. Of course, it was decided upon by a committee of 3 who were independent of the study. But even then, it's interesting to note that clinicians diagnosed VAP in 80 patients, while the committee diagnosed VAP in only 60 patients, first. And secondly, the committee themselves had disagreement about the diagnosis in about 22% of cases. So this brings to question the problem that we sort of universally face in the diagnosis of VAP, and the precision of diagnosis and the possible bias that's associated with the diagnosis of VAP. How about the sample size? The sample size was calculated based on an incidence of VAP of 68%, but during the study they found that the incidence of VAP was much lower at only 29.4%. Hence, the study was probably underpowered to look at the primary outcome. And last, it's important to note that this study is in regard to patients who suffer after hospital cardiac arrest with a shockable rhythm. In hospital arrest and patients with non-shockable rhythms may not benefit based on the results of this study. At the end of all that, is this study going to change your practice? For me, working in India, we very rarely get patients who are resuscitated out of hospital, who have a shockable rhythm, defibrillated at the scene and transferred expeditiously to the hospital. Such numbers are very, very low in this country, and by and large, we don't see many patients in this category. We generally go by clinical evidence or radiographic evidence of aspiration and treat them appropriately with antibiotics. And also, we wouldn't, generally speaking, use prophylactic antibiotics post-cardiac arrest unless there is a definite indication to do so. So that's it, folks, for today. Till we meet again next time, goodbye.